Good afternoon, or if you're calling from the West Coast, good morning, everyone. Well, thank you for being here. My name is Brooks Roach. I am a diabetes education specialist here at Diabetes Canada, and I would like to begin by acknowledging that I am joining this webinar from the traditional and unceded territory of the Mi'kmaq people. And wherever you're joining or watching from, I will invite you to express gratitude for the land on which we live and to acknowledge the past inhabitants of the Indigenous lands that we call Canada. We are here today to talk about the importance of influenza vaccines, specifically for people living with diabetes. We're joined by two wonderful experts, Dr. Susie Hoda, who is an infectious diseases specialist and epidemiologist at Toronto's University Health Network and an associate professor at the University of Toronto. Thank you, Susie, for being here. We also have Mike Boyven, who is a pharmacist consultant with ComPharm. So welcome and sincerely thank you to you both. So the way that today is going to work is our experts will be answering some key questions that they have been hearing from patients, and we'll also be taking questions from you, our viewers. So some questions have already been submitted, and you can feel free to ask any questions that come up over the course of the webinar by replying in the comments below on Facebook Live. So we'll go ahead and dive right into some key questions that we've received on influenza vaccines and diabetes. So Dr. Hoda, we'll start with you. And the first question that I'd like to ask is, if you could provide us with sort of a basic definition of influenza or the flu and what symptoms to look out for.
Sure. So, what we commonly call the flu refers to the influenza virus. And this is a virus that tends to infect our upper and lower respiratory tracts. And when it does, it can result in symptoms like runny nose, sore throat, nasal congestion, a cough, and fever. And you can also have sort of general symptoms like muscle aches, feeling really tired and lousy, sometimes even some stomach symptoms, gastrointestinal upset, diarrhea, things like that. And most people will recover from those symptoms within about 7, maybe 10 days. But you can pass it on to other people from starting from about a day before when you start getting those symptoms to about 5 days into your illness when you have the most virus that you're shedding. And the way that you're able to transmit it to people is through expelling respiratory particles, so particles from your respiratory tract that contain the virus while you're infectious. And people around you who might get exposed to those particles will inhale them. And the other thing is you can also then contaminate surfaces around you with the virus. And then others who touch those surfaces and then touch their nose or eyes or mouths will then potentially introduce it into their bodies and get infected. So that's really how it works. We do tend to see influenza viruses circulate around a certain time of year. And that's usually between around October, November, generally November, till about April or May. May would be very late, actually. It's more till the end of April. And it usually peaks around December, late December, early January, somewhere around there. And it's often multiple different strains or sort of subtypes of influenza virus that are circulating at the same time. And some will kind of predominate in a certain season. So there might be one that really kind of takes over and tends to cause most of the infections. But the virus itself is very capable of changing and mutating. And that's one of the reasons why it's really important to be getting influenza vaccines on an annual basis, because you, first of all, don't get protection that's offered for too long by a vaccine. It does kind of wane that immunity. But also, you need to match the different subtypes or strains that are within the vaccine with what is circulating that year. So it is important to recognize there are different strains of influenza. I'll say that in this past influenza season or kind of respiratory virus season, we haven't seen a whole lot of influenza. Actually, globally, we haven't seen much influenza in the last 18, 19 months. And I think that the theory is a lot of that is because with the COVID-19 pandemic, we've been using measures that are common to reducing transmission of any respiratory virus, including COVID. So things like all the masking we're doing, especially in indoor settings, and reducing our social contacts and keeping physical distance and lockdowns that we've experienced has really kind of changed fundamentally the epidemiology, the numbers, trends, everything that we see with influenza, but also other respiratory viruses. And so that's been really helpful so that we can respond to the pandemic appropriately. But it also does make us recognize that as we're starting to release society from some of those measures, we might see influenza and other respiratory viruses that we can't forget about that circulate at the same time cropping up. So we really need to be prepared and do what we can to prevent, the harms of influenza virus this season.
Thank you, Doctor. That's really helpful, and I think a lot of people, I've heard this trend of maybe vaccine fatigue, where people have there's been so much time and energy invested into the commitment to get a COVID-19 vaccine that this feels like, haven't I already done that? And I think highlighting that difference is really important. And I think for a lot of viewers, another point that's frequently raised and frequently asked is about the relationship between influenza and diabetes. So could you speak to sort of the change in risk factors if someone lives with diabetes?
Absolutely. So if you have any kind of diabetes, so that means type 1, type 2, or even gestational diabetes, you're actually at risk for having complications of influenza infection. So I already talked about what symptoms are really common with a usual influenza infection, but a proportion of people will actually also have complications, which include typically bronchitis or pneumonia, so a lower respiratory tract infection that's more serious and quite often does result in hospitalization, or things like middle ear infections, sinus infections. And the other thing that's really relevant is kind of a less recognized complication of influenza infection that's especially important for those with diabetes is you can have heart attacks or strokes related to your infection. So it can precipitate that. So there is a connection between heart disease and cardiovascular uh, health and wellness and influenza infection. So that's an important relationship to recognize. On the matter of sort of complications of influenza infection, very rarely people will actually suffer from really serious consequences of influenza, including things like inflammation of the brain or the lining of the brain, or things like inflammation of the heart muscle itself or the lining of the heart muscle. So these are really important things to know about. They happen uncommonly, but again, if there's a way to prevent it, that's kind of where my mind goes. What can we do to try and prevent that? And that's what we're going to be talking about today. One other thing to keep in mind, sort of a final relationship between diabetes and influenza, would be if you had diabetes and you got an influenza infection, it could actually make it very difficult to control your blood sugars, partly because any infection will then increase your blood sugar levels commonly. But the other part is characteristic of influenza is that people lose their appetite sometimes. And so it can be a little bit hard to, gauge insulin levels and you might run a risk of hypoglycemia as well during the infection.
Thank you. And so recognizing that interconnection that you've just highlighted, next question is going to go to you, Mike, and that's if you can explain the sort of added importance and effectiveness of immunization if someone lives with diabetes. And in addition to that, as we've seen over the past, say, 18 months, are there any other strategies in addition to a vaccination to reduce the spread of influenza or these related viruses?
It's a great question, Brooks. So Dr. Hoda really touched on it already, is that we've seen so little influenza through globally over the last few years. So we know the strategies that we're using for COVID-19 are working to reduce the risk of a lot of these respiratory tract infections. But the key thing is, as we relax these measures, there's going to be potential issues that we see. So people said, well, why did I bother get the flu shot last year when there's so little circulating? Why don't I just wait and see if it comes back? Well, first and foremost, it takes at least 2 weeks for the vaccine to actually get enough levels of protection within the body. So if you wait for the flu to circulate in your community, it could be too late. And this is especially important for people like you who have diabetes, who are at much higher risk of these complications that Dr. Hoda qualified. What you may not know is that 5 to 10% of adults globally and 20 to 30% of children are infected in a typical year with influenza. A lot of the healthy people recover without any issues at all, but people like patients with diabetes or some of our older patients are higher risk of complications, including heart attack or stroke, pneumonia, hospitalization, and we know that influenza will kill a portion of our population every year. And this is why it's so important to protect our patients. What you also may not know is that here in Canada, pneumonia and influenza or the flu is amongst the top 10 causes of death that we see every year. So this is something that's really important for you to take care of yourself. If you're focusing on your diabetes to keep healthy, this is a key thing that you can do to actually help keep yourself healthy and out of hospital. Now, if you're looking at ways to talk and protect yourself, we talk about the flu, and I think one of the most effective ways, if you do not want to get the flu, just like if you do not want to get COVID-19, the best strategy is to get the vaccine. Now, we hear every year where people will say, well, the vaccine doesn't necessarily work every year. And you'll see it in the media sometimes where they'll say, well, the vaccine is only 50% effective. To let you know how this works is that the World Health Organization every year tries to think of which vaccines are going to be, which viruses are going to be circulating with influenza every single year. And they do this in March, April, May to predict what's going to happen in our flu season here in the fall. Sometimes they're perfect and the vaccine has very high efficacy, and sometimes they're not as good in terms of the way that the vaccines end up working. But the key thing is that even when the vaccine is not a perfect match, we know it keeps people out of hospitals and reduces the risk of death. So it's so important that one of the key things that you do is to get that vaccine every year. Now, Brooks, you were asking about what other measures you can end up using. Like everything that we're doing for COVID-19, masking seems to work. Washing your hands, staying away from people that could be ill, staying home when you're sick or anyone else in your family is sick will reduce the risk of spreading the flu within your communities once we go back to normal.
Thank you, Mike. And I think the point you make about that delayed onset, or if someone is waiting to see if there is a flu outbreak, it's almost like waiting to see if there's a flood before you flood-proof your home. It's once the signs are there, you're going to wish you had protected yourself in advance. Our next question is going to be to both of you, and it's that that there's been a lot of discussion around, a well-founded discussion on getting the COVID-19 vaccine distributed to different age groups. And I'm wondering if you could share some thoughts on who is eligible and who should get the influenza vaccine based on age, based on demographics, where someone lives. What prioritizes an individual?
Sure. So maybe I'll get started, and Mike, please feel free to jump in. In my opinion, everybody should get the influenza vaccine. And here in Ontario, at least, and in many provinces, it's funded to be available to everybody. But in particular, I'd recommend those who are at risk for having complications related to to influenza infection. So that does include diabetes. There's a whole long list of health conditions that actually do put people at risk: heart disease, liver disease. Also, age is important. So if you're over the age of 65, or if you're a child, you're at higher risk of complications of infection. So these are the kinds of risk factors. There are other things as well that are important to consider. So if you are a caregiver, you live in the household with somebody who's at risk for severe complications of influenza, you should also get vaccinated. Or if you live in an institution like a long-term care home, or in a sort of more congregate type setting, then it would also be important to protect yourself. So I'll start there. And Mike, do you have other comments about what you think?
Yeah, and that's a great point. I think one of the key things is, as you mentioned, everybody over the age of 6 months should be getting the vaccine. The key groups are the really young and the really old. They tend to be some of the people at the highest risk of complications. So the kiddos that we see and that we're sending off to school that we're worried about, that we can't yet vaccinate against COVID-19, we can vaccinate them against influenza. We can protect them at this key point. So this is a key group that you can look at. But also from our older patients, anyone over the age of 65, there are different vaccine options that are available for our individual people that are over the age of 65. Experts recommend that they get a high dose influenza vaccine. So if you're over the age of 65, I would encourage you to get that vaccine. In many provinces, this will be paid for by the government's plan. So strongly encourage you to get the high dose one. It may reduce your overall risk. But one of the key groups that I focus on are the young and healthy people. And we've seen this with COVID-19, and we've seen this with influenza in the past, is that I'm young, I'm healthy, I don't need to worry about it. I'm going to be fine if I get the flu. And the odds are, you're probably right. You'll probably be sick, but you'll probably recover completely. The fundamental issue thing is two things. One thing is that if you get sick with influenza, there's a good chance that you're going to be sick on your back for up to 7 days. Most people recover, as I mentioned, within 7 to 14 days, but 7 days you could be out of commission. So if you're a young person, you're young and you're healthy and you're feeling great, the problem is that you can miss 7 days of work or 7 days of school. And this could be a significant issue if you're trying to, in university or in high school, Or if you're working at a part-time job or a full-time job, you may be going without that pay. The most important thing that we see is that you have an important thing about reducing the amount of transmission in the community. I would hate to be a young person who's young and healthy, but then to give it to my grandmother, and then I'm running into somebody, or to give it to somebody with diabetes, and they end up getting really sick with it. So anything that we can do as a group to actually reduce the overall risk, I think is very important.
Yeah, I wanted to actually maybe expand a little on that because I think that's such a key point. We get vaccinated against influenza to protect ourselves, but also to protect society, right? So there are really two goals there. And for the individual, especially if you're at risk, it can reduce your risk of hospitalization by a third. If you get vaccinated, and especially if you're older, it's got much more effect. But it also reduces the risk of death particularly in people with at-risk conditions. But in terms of the society as a whole, we have to think too about what's been happening with this pandemic, and our healthcare system is very vulnerable right now. We've got shortages of healthcare workers. People are quite fatigued, and the healthcare system is not as resilient in terms of dealing with additional, preventable illnesses. And so, if hospitals start to fill up not just with influenza, but also COVID and other respiratory viruses, then it makes it very difficult for us to provide the kind of care that we need for everything else as well. So, these are important societal considerations as well as you make your decision about getting vaccinated.
Yeah, that's a great point. And one of the key things that I focus on is that we see in our patients with type 2 diabetes, there are many of these patients that are over the age of 65. And one of my key worries that I see is that, some people say, well, I'm older, or something happens to me, it's not the end of the world. The problem with influenza is there's many patients that will end up getting it that actually don't end up dying from it, but end up having permanent disability from it. So if you get hospitalized, or if you get a severe case and it leads to damage in your lungs, all it does is it increases your overall level of frailty. So by increasing your frailty, you may not be able to live as independent as you were before. Some of these people never recover to the way they were before. And this is such a simple measure that you can end up doing. By getting this flu shot every year, you can reduce your risk of this happening to you. And that's the last thing I'd want to see to happen to any of you or to any of your family members.
Yeah, thank you both. Those are really, really important points. And I think, that idea of it's not necessarily for us, it's for those around us, and that vaccination does not necessarily stop transmission is a point that I see raised in the comments coming in from Facebook. So it's to consider it more as an individual, as a vessel that could pose harm to others. And that's why it's so important. So with that, making reference to questions coming in via social media, we're going to open it up to questions. And the first question that we have that's been submitted is, and this, for context, at the time that this webinar is being recorded, there are some discussions taking place at the provincial and federal level around a third shot of the COVID-19 vaccine, specifically for folks who are immunocompromised. So the question is, would a third shot for COVID-19, if it is approved, have any impact on getting the yearly flu shot?
So I guess I could start off with that. There is some work that's being done to kind of review right now what the implications are of sort of co-administration of different vaccines. And, right now we don't have any evidence that if you got your third shot of a COVID-19 vaccine and you had to get your influenza vaccine shortly after that, that there would be a problem, that there would be any interference between them. But to be cautious, the recommendation remains that if you get a dose of your COVID-19 vaccine, you should wait 28 days before you get another vaccine. So that's what we would prefer to see happen. If there's some emergent reason for this, would be unlikely for an influenza vaccine, but say another vaccine to be given in a shorter time frame than that can be done. You do have to speak with your healthcare provider to understand the risks and benefits, but it can be done. But I don't think it's going to interfere. It's not going to cause a problem. You can wait a little bit to get your influenza vaccine if you do indeed need to get a third dose of a COVID-19 vaccine.
Okay, thank you. The next question that's been submitted is kind of just an operational one, and it's, when will the influenza vaccine be available this year?
Mike, do you have the
Yeah,
insights?
that's always a really great question. It all depends. Every public health unit in the province is quite different. So we see some variances in terms of when they get actually in to primary care providers, so to your local pharmacy, to your local family physician or public health, to be able to administer them. So the key thing is that we know with people with diabetes, you're on medication. So your best bet is just to connect with your pharmacist. They are there all the time. They will be able to tell you exactly when they're getting their flu shots in. And we'll know that probably by the middle of October, but it varies every year. So you will have to just double check with them and they'll be able to let you know.
Okay. We have another question that is regarding if vaccination is effective at stopping transmission. So I'm wondering if you folks could speak a bit to that. And I think that leads into a question around debunking some common misconceptions around vaccination. So I'll leave that with you folks if one of you would like to take that on around the effect on transmissibility that vaccination has.
Do you want me to take a stab
Yeah,
at
go for it first.
starting with that? Yeah, I mean, so I think, it really depends on how the effects or the outcomes are measured in different studies of different vaccines, just how much we can comment on this. And for influenza, I think we know that transmission can occur, and we're seeing this with a lot of different viruses. And it's not necessarily completely prevented by vaccination. But when you think about, even a moderately effective vaccine, like what we have with seasonal influenza vaccines, preventing infections from occurring, say 40 to 60% of the time, if that's what the, a certain year's vaccine effectiveness is, that reduces the opportunities. So in a way, it does still have some impact on the risk of sort of community transmission of infection. So if enough people get vaccinated, it will have an impact. So it's a bit of a hard thing to explain, I guess, but it's about having a community-wide effect. But for the individual, yes, you may still get infected because it's not 100% effective at stopping symptomatic infections from happening. And yes, you may transmit on to others if that occurs. So, I think that's kind of the bottom line. The other thing I'd say is, again, we focus so much on the transmission piece, on the symptomatic infection piece. And I think the COVID-19 experience has helped us to learn that sometimes you have to keep your eye on what's truly important, and that's the really severe illnesses. And, the risk of hospitalization, like I said, being reduced by a third. With influenza vaccination, that's an important outcome. The risk of death being reduced as well, and by up to 25% from heart disease and stroke in those with diabetes in particular, with influenza vaccination. Like, we're getting some pretty good data out there that it does make a difference. So I think that counters that whole question and the relevance of whether we should focus on transmission.
Yeah, and the other thing that you can focus on is the way we look at vaccination is it's protecting you on the inside. So you can actually inhale a virus, a respiratory virus, it can grow in your nose, and you may be able to spill some of this virus out. But if that virus was to get into your respiratory tract or was to get into your body, having the antibodies from the vaccine can protect you. So it can reduce your risk of transmission, can reduce your risk of really severe outcomes. So it's a key focus. So everybody says, well, if you're still going to be able to transmit, do I still need the vaccine? Of course, because we want to protect you and we want to protect everyone around you.
Yeah, exactly.
Yeah, that's a great point. We have another question that is from a viewer who has LADA, or latent autoimmune diabetes in adults. And this person's wondering if they should consider getting a third COVID-19 shot if it becomes available.
Yeah, right now that's not one of the approved indications among the group of individuals who are considered as immune compromised, and where there's enough data that we feel it's important to give a third dose at this time. And the rationale for that is not so much thinking boosters, but recognizing that some severely immune compromised people actually don't have enough of an immune response in the first place when they get the series of 2 doses. And so a third one seems to augment that response, and that's really the rationale behind it. So we do have to be a little cautious with the language we use. We haven't seen that yet with certain groups, people with autoimmune diseases, for example.
And what's very interesting with it too, as well, is that the COVID-19 vaccines have been quite different and unique. Whereas in some conditions where we see very poor responses to vaccines, so patients that have had chronic kidney disease, don't respond well to some vaccines, but seem to respond really, really well to the COVID-19 vaccine. So as we get more and more of this information, I think we can make better and more specific recommendations for our patients. But as Dr. Hoda mentioned, we know that patients who are on immunosuppressive therapy, so patients that have RA, rheumatoid arthritis, psoriatic arthritis, and they're using biologic therapies, those patients are at higher risk of not having enough antibodies coming from the vaccine. So those ones are typically prioritized for that third dose at this point, but that may change. And so as we know, as more things will change, we'll learn more. So for you, I would just wait and see. There's nothing really at this point, but we may have more information for you a month from now, 2 months from now, or a few months from now.
We have another question, and this is sort of a down the road, looking down the road, and it's regarding what measures have been taken to protect people if mRNA vaccines start to cause delayed immune system responses like diabetes. So I suppose the question is around what preparations, if any, do you folks know of that have been made for longer term potential implications of current vaccination?
That's an interesting question, actually. And I think if I understand it correctly, it's talking about how would we even know if there is a signal and how would we respond to it, right? So after any new vaccine therapeutic is on the market, there's always some post-marketing surveillance that occurs. And I think there's an especially important, big focus on that with the COVID-19 vaccines because of the magnitude of the vaccination effort that is going on, right? Like mass vaccination at a level we've never done before, but also new technologies behind some of the vaccines that we're using, et cetera, et cetera. And so the clinical trials that originally were used to help with getting authorization for these vaccines are still ongoing. The participants are still a part of a follow-up in the protocol. And we should be getting some longer term data on what are the risks of developing a problem like diabetes or an autoimmune disorder, for example, or anything else, any other signal that might emerge longer term after having any of these vaccines. That's one way we'd get it. The other thing is that there's ongoing, like I said, just I guess broad post marketing surveillance that's occurring in which adverse events or any data on that is being recorded and collected, and it will be analyzed over time to make sure that, from a big society perspective in real life, we're getting those signals as well. In terms of how we respond to it, I think it's, again, just the healthcare system has to be prepared for all the demands that might come from this pandemic. And that includes people who've suffered from long-term consequences of COVID infection itself, which we're still learning about. And there's some interesting data coming out on that, on the magnitude of what that could look like within, Ontario and Canada. And also, some of the therapeutics that are being used, as well as the vaccines that are out there. So yeah, we just have to be prepared for what those consequences would be.
Yeah, I think one thing to jump in on this one, Brooks, is that what I'm really concerned about and what I've seen over the last year to year and a half, especially in patients with diabetes, is that we're seeing people forego the regular care that they've actually had. So some of these people have stopped some of their medications or haven't really been managing their diabetes as well because they haven't been able to have access to their diabetes educators, their family physicians as easily. And I'm really worried about what that impact will have over the long term. Like we talked a little bit about the link between cardiovascular disease or heart disease and people that don't get their flu shot. So if you get the flu, that can put you at higher risk. But if we don't control your diabetes, this can put you at higher risk of complications as well. So your heart, your kidneys, your eyes, your feet, all those can be affected. So, although a lot of people are worried about what is going to be the impact of vaccines, my primary basis of all the vaccines we have, and Dr. Hoda, you can jump in, is that I've never seen data showing that we see any prolonged adverse effects or side effects 6 months after. So side effects that occur 6 months, 8 months, a year afterwards. Typically, we see this shortly after immunizations. And I'm confident in terms of what we're doing is that we're immunizing so many people, side effects that we may have never seen. Never came up in any of the trials. We're seeing now, because once you give this to 1,000 people, 2,000 people, we're giving it to millions of people, millions and millions and millions of people. So even the smallest signals can actually show up on some of the bases. So am I worried about things developing in the long term? Probably not, but we're hoping that, if anything comes up, we'll identify them and we'll address them just like any other issue.
Yeah.
We have another question. This is regarding the influenza vaccine for the coming flu season, so 2021 to 2022. And it's simply what is new with this vaccine, or do we know that information yet? As mentioned, you mentioned, Mike, it comes from the World Health Organization in the spring. Are you folks aware of what specifically, how it's composed? Or I suppose within that question, is that something that folks really need to dive into the details of?
Yeah, I mean, so it's funny every year. In our occupational health and safety department, we'd have this, discussion before flu season, before we ramped up for our campaign to immunize and get all excited. And the question that people always waited for is, what's in the flu vaccines that we're giving out this year? And when you think about it, it's kind of irrelevant in a way. It's really just it's what has been decided is most likely to be circulating based on what circulated in other parts of the world during their seasons, which are kind of the flip of our seasons, in the Southern Hemisphere, and temperate regions where it circulates all year round. So the CDC did release it. I haven't seen it. I was scouring our NACI statement, and for whatever reason, I couldn't pick it out as easily, but I know that we end up having the same constituents as within the US, typically. Correct me if I'm wrong, Mike, but
That's right.
That's what I know. So there are two different types of vaccines that are out there. There are ones that are grown within eggs, so they're egg-based vaccines, and then there are some that are more cell or recombinant, different technologies used to make those vaccines. And the components are slightly different, but they always have two of the influenza A subtypes in them. And depending on if you have a vaccine that is what we call trivalent, so it has 3 strains within it, that it covers 3 strains within it, or quadrivalent, so it covers for 4, you would either have 1 or 2 of the B strains, subtypes that are in there. So in the egg-based this year, it's A Victoria H1N1, if this is relevant to anybody, the A Cambodia H3N2, and the B Washington Victoria lineage, and B Phuket Yamagata lineage. And that's the ones, I mean, we typically do give out more of the egg-based vaccines. There's a slight difference in what's offered in the other type of vaccines this year.
And I think that's been a really key issue, is that we used to, back in the day, like if you look at me, I have a lot of gray hair now, and it's been around for a while. Like we had one vaccine for everybody. Whether you were 6 months or you were 85, it was one vaccine for everybody. The fundamental issue now is we have lots of different vaccine options. So first and foremost, there is, if you're worried about needles and you're under the age of 50, and you're 17 to 50, you can consider getting the flu mist if it's available this year. It's actually a mist that you can use inside the nose. It is an effective vaccine, and you wouldn't have to get poked with a needle. We have vaccines that are specifically designed for kids underneath the age of 2. We have vaccines that are specifically designed for patients over the age of 65. And then the new technology, as Dr. Hoda mentioned, these are ones from cells. So they never touch an egg. So these ones for patients, although all vaccines seem to be okay in patients with egg allergies, these ones are especially safe for those individuals. So the key thing is there's lots of different vaccine choices you can end up using. Out of all of the ones that are mentioned, the key thing here is that if you're over the age of 65, consider a high dose influenza vaccine that has 4 times, the amount of the antigens, or the amount of the stuff that we're developing the antibodies to in that. So it really helps older people that tend to have a weaker immune system. But for every other person, take the first flu shot you're offered. Doesn't matter which one, all of these are going to offer good protection for you.
Yeah, that's really interesting. And I think for our viewers, I'll highlight 2 really interesting points from that answer, which was fantastic. And first is that there are a lot of different types and media through which you can get this vaccine. If you're needle averse, you can get it via a mist. If you have an egg allergy, there are ways to circumvent that challenge. So there are, it's been made very easy to become vaccinated is the key point there. And it should be, take advantage of that if you can.
Can I just add one thing to that? And one of the key things that we see a lot with vaccines is that people they don't normally want to mention it to healthcare providers that they're scared about needles, or they don't like the pain of their vaccines. We have lots of options that we can end up using, that if you need to get a needle, we can reduce the pain from that without a problem at all. The key thing is that you have to bring it up to the attention of the people that are giving you the vaccine. They'll work with you. We have creams, we have things that can end up helping, so you will barely feel the needle that's going in. Will make you much more comfortable. And it's just a matter of bringing it up, and we can do our best to end up helping those out.
Yeah, thanks, Mike. I think the other point that I found really interesting, and it's when folks talk about, the question arises, what's in the flu vaccine, or how is this being developed? And Susie, the point you raised about it actually being a kind of a rolling collection of data from whether it's the Southern Hemisphere or more temperate regions around the equator, we're dealing with a sample size of potentially billions of people. So this is, as much as the criticism can be lobbed, as mentioned earlier, if it's only, let's say, 40 to 60% effective, that's still on the scale of billions of people, and we're basing this on this really constant and expert collection of data that's coming in from all over the world. So it's really worth noting that that's such a powerful concerted effort. On that note, there's a follow-up question that just came in, and it's, would or could there be a missed form of the vaccine for COVID-19?
I think there are some people who've been trying to work on intranasal vaccines for COVID-19. I don't know a lot of details about it, but there is a theoretical benefit of getting to the right kinds of cells by administering the vaccine directly to the nasal passage. But I don't think any of them are close yet to coming, going through clinical trials and going through the entire process. But maybe one day.
Yeah, and it's an exciting notion from a theoretical basis, because we're worried about with these respiratory viruses, the virus gets into the nose, it can grow in the nose and you could potentially transmit it. But if we push that vaccine right into those passages and touching on those tissues, we maybe offer some great protection for us. So that may be a potential for boosters moving forward, but we're not sure as of yet. And I haven't seen anything that it will be a month from now, 2 months from now, or potentially a year from now. We'll get more information as they do more testing.
We have a question from a parent of someone with diabetes, and they say, my 15-year-old son won't get the COVID-19 vaccine. He has been watching the news and saw that it causes heart inflammation in males his age. He said, I already have diabetes. I don't need another heart problem. I don't need a heart problem. So the question is, do you know the percentage of intersectionality in risk for young males? But I think most importantly is the second question: how can I encourage him to get it?
Can I just jump in really quickly on that one before we'll let Dr. Hoda take the heavy lifting on it? There was a paper that was published in the New England Journal of Medicine just a few years ago looking at what are the potential side effects of using an mRNA vaccine. So this would be the Pfizer-BioNTech and the Moderna vaccines that we have here in Canada, versus if the person had COVID-19 infection. The data is actually showing that a patient is at risk of heart inflammation if at about 3 to 4 times higher risk if they get COVID-19 than if they have the vaccine. So for a young male who actually has diabetes, who's at already risk of actually getting a heart condition because of his diabetes, I'd be very, very concerned from that key component. The fundamental issue is, and I've had many, many conversations with people that I'm unrelated to, not family members, not direct patients of mine, that just want to ask questions. So from a parent perspective, I find it's very hard for a lot of parents because it seems like that you're just pushing on a 15-year-old or a 16-year-old, telling them what to do. The key thing for them is to try to find a healthcare provider that they work with. So this could be an educator from their perspective. They could be the pharmacist, a family physician, a nurse educator, a dietitian, endocrinologist that they see on a regular basis, to actually have that conversation about why they should end up having it. I can tell you, I have kids that are in that age group. I feel very comfortable that my kids are protected. I feel it actually provides me some relief that they are, and it's the biggest thing that we can end up doing to help us all get back to somewhat normal life again.
Yeah, I actually don't really have a lot to add to it. I mean, you can look at what our surveillance data over time here and internationally has shown. And yes, there have been cases of heart inflammation or inflammation aligning the heart particularly after the mRNA type vaccines. However, I think that, that's just one source of information. And the study that Mike referred to is really, really, it was a game changing study in many ways, because it really did show comparatively what the risk is based on vaccination and based on not getting vaccinated, especially if you're in an area of higher prevalence, or, as we go through the different waves of COVID-19. And so I do think that, the risk of not getting vaccinated is much higher than the risk of any of those kinds of rare but serious outcomes after vaccination. And I do also wholeheartedly agree with talking to somebody independent and who you feel like you can trust about this, who would be knowledgeable in the area. So talking to your family doctor, or, there are a whole slew of different people who would be very happy to provide that kind of advice. And it just changes the dynamic of the discussion altogether. So really would encourage that, especially as school started up, and your opportunities of being in close contact with people is going up through the fall. It's an important time to be having that talk.
Yeah, the other thing is that I can tell you from the work that I've done with vaccine hesitancy, people that are worried about vaccines in general, is their minds can be changed over a period of time. It doesn't have to be today. All of a sudden, something can end up happening where it could be changed. So it's really about not closing the door to the discussion. We really want that if he's not ready at this point, get him to think about it, talk to other people, but he may be ready in a month or so. And if that happens, you know what, we'll part the gates for him and make sure that he gets protected when he's ready for that. So don't close down the discussion. We'll work with him if he needs that help.
Yeah.
Thank you, folks. We have a question from someone who lives with fibromyalgia. And their question is, would that be considered as an autoimmune disease like RA, rheumatoid arthritis, that could qualify for a third COVID-19 vaccine? And I'll sort of take a shot at this. And if I miss anything, please feel free to fill it in. But essentially, I would refer you in those cases to check your provincial health ministry, the information they're putting out. And I'm also going to make a note that for Diabetes Canada to share any and all updates that come in when it pertains to a third COVID-19 vaccine for immunocompromised individuals. So again, because there is some variability on timelines right now and on different jurisdictions, I don't want to give you a wrong answer, but stay following our pages, and I'll do my best to get that information distributed as soon as it's out there. But also stay tuned with your provincial or territorial ministry. So folks, I think that's all for questions that have been submitted on Facebook. And I want to thank you all for submitting your questions. And there's obviously a lot of thought going into this and a lot of curiosity. So it means a lot to have you here asking. And I'll pose one final question to our guests, and that's sort of if you have anything you'd like to add at this point, or specifically if there are any common misconceptions that you would like to address. I'd like to give you that chance now.
I'll throw out one misconception. This happens. This comes up, I think, every time I talk about the vaccine, and people often think that you can get influenza from the influenza vaccines, and you absolutely cannot. They're not designed to do that. And the vast majority of the vaccines that we do give for influenza are inactivated vaccines. They don't contain sort of live virus. The exception is that flu mist vaccine, the intranasal spray that we talked about, that does contain a live form of the vaccine, and why it's not recommended for people who are immune compromised or pregnant. And there are a number of sort of parameters around who could receive that for that reason. But you cannot get influenza infection from these vaccines. You might feel a little bit lousy the day after, maybe a couple of days after you get your shot. And this is really just a sign, again, that your immune system is reacting appropriately to the vaccine. So you might get a little bit of fever or chills, you might feel muscle aches, you might be tired. That's not influenza. It's your body doing the right thing and trying to mount a good immune response.
One thing I want to add that I've heard with COVID-19 vaccine, we have also heard it with influenza and vaccines in general, is that people are saying that there's no safety measures, that these vaccines are just big pharma is pushing them through. We have incredible standards here in Canada and in the US and in different regions of the world for the way that vaccines are approved. We have less tolerance. They're much more scrutinized than a standard medication out on the market. And the reason why is we're giving them to healthier people. So we have to be very, very careful from that standpoint. All the vaccines, the process that goes through from Health Canada, whether it was COVID-19, people say, how could they approve it so quickly? The reason why is they approved the vaccine for COVID-19 so quickly is so many people were affected. We ended up getting data fairly quickly. And because it was a pandemic, we did all the safety measures in a very short period of time because we had so many vaccines that were being administered. None of the steps were actually compromised, all the same safety standards. And even today, we're still doing these safety standards to make sure these vaccines are safe over the long term. That's why we can find some of these rare side effects to make sure that these are safe over that long term. So regardless of which vaccine you receive, all of them have gone through the same safety standards. So I would encourage you not to worry about thinking that these got onto the market, they're experimental drugs. These are highly tested pharmacotherapies or vaccines that can actually end up helping to protect you and keep your family safe.
Yeah, thank you both. That's really, I think it's powerful to hear that information coming from both of you with the expertise that you have. So thank you. Before we wrap up, I'd like to take a moment to tell you folks how Diabetes Canada is helping to support Canadians impacted by diabetes, especially and including during the flu season and as the pandemic continues. So you can feel free to visit our website or our social media to stay up to date on our work and on resources that we're putting out. And I also see a question regarding, would we consider doing media blurbs on the impact of not getting COVID vaccines when a person has family or relatives with diabetes? And the short answer is, I think that's a really impactful way of framing it. So I'm going to mention that to our team. We have a great team, and I think it's really super important to give people resources that can help to frame things coming from an expert body. So thank you for raising that question. To access these sort of resources and for specific direction, I would recommend you can feel free to call our helpline at 1-800-BANTING or to email info@diabetes.ca for any questions, and we'll do our best to help. So with that, I want to say a huge thank you to our guests, Dr. Susie Hoda and Mike Koiven. So it means a lot to have you here and have you sharing such a, investing a lot of your time and energy into providing the best answers you can. To our guests, thank you as well. Please don't hesitate to reach out. And I personally, I found this to be such a valuable webinar. I hope the same is true for you as a viewer and that it's been helpful. And please feel free to contact us for any further information, for any questions, or to be connected to our experts. So thank you very much, and take care, everyone.
Thanks so much.
Thank you.